Welcome back. We're getting ready to finish up chapter 2 in the text, and it's going to be a fairly short segment this time, but we're again trying to wind up the role of what does an economist do? Are economists beneficial? How many economists are individuals trained to be an economist? Do you actually see in healthcare? It's just it depends on the health plan. It depends on the provider groups that we're talking about. You have several individuals trained as economists that work for consulting groups. So it's not out of the ordinary to see that happening. It's somewhat rare to have somebody, especially in a small health plan or the small hospital or small provider group that's trained as an economist to actually be doing the work. But they usually can grab somebody that's got a math or statistical background. They may grab somebody that's has a finance background. But what you will find is they can be extremely valuable, especially to the decision makers, because the decision makers are motivated by incentives, and they maximize self-interest and allocate resources to optimize well-being. They often, and this is not just, when you're talking about decision makers, I'm not just talking about the decision makers on a provider group or a health plan. I'm also talking about the decision makers in a government agency, or the decision maker just in a consumer. When I go to see my physician, I'm a decision maker. Or when my wife goes, she's a decision maker. I mean, we're all decision makers because we're, again, making choices. We are looking at opportunity cost. We're optimizing self-interest. We're making choices at the margin. So, but unfortunately, we often practice what I think they talk about in the textbook is practice rational ignorance. And basically it's kind of I don't know, it's not a term that's used very much, but it's incomplete information because the cost of information is more than the perceived worth. So if you're not feeling well and you're trying to decide whether or not to go to see your doctor, you can go out to, well, WebMD's one, WebMD out on the internet, or Google, or do a search, and you'll get a huge amount of information, and you can spend hours sifting through that information trying to decide, well, I don't feel well. Do I go to my doctor? Do I pay the transportation costs? Do I pay my deductible coinsurance copay? Do I pay for, I've got to pay parking when I go see my physician. And, do I spend, what's the value of my time worth, because for me to see my physician, by the time I drive down, sit there in the office, talk to him, drive back home, I'm probably looking somewhere 2 to 3 hours, depending on traffic and depending on how punctual he is. So you're looking at, my time's worth something, probably worth more to me than the physician thinks his time is worth to himself. But still, it's just a matter of do you spend the time? And at that point, spending hours trying to figure out whether you need to go to the physician, some people just don't think it's a perceived worth. So that's what they're talking about. They practice rational ignorance. And then we've talked earlier about scientific model with hypothesis observations, theories, hypothesis testing, quantitative methods. And, when you develop that hypothesis and build your model and test it, I can't count the number of times that I built models and tested them and had to go back to the drawing board because something's not right. Either there's an issue with the data I'm bringing in, or the assumptions I made aren't working, or something. So it's, unfortunately, when you're doing hypothesis testing and you're trying to develop a model that you want to present to, the CFO or the CEO or, chief actuary, you don't want to have a model that's flawed. So you're going to test and retest and retest to make sure you've got something that's going to predict and forecast with accuracy, because you're talking about providing information to an individual that's going to be making decisions for the company at large. And again, as an economist, we're trying to understand the data, trying to explain it, trying to predict. Models actually organize knowledge and explain behaviors. And then, we talk about the microeconomic models explains the behavior of an individual decision maker. And again, an individual decision maker I can be an individual decision maker. You can be one. The CEO of Meharry is an individual decision maker if they're making it in a vacuum. I don't know how they make the decisions at Meharry. The president, CEO, whatever his or her position is, they may have to develop a strategy and go to a board of directors to get it approved. I don't know, but it depends on who that decision maker is. And then, optimization implies the best action given the goals and objectives. You're talking about constrained optimization accounts for scarcity of resources. So when we're talking about optimization, individual actors and policymakers determine choices in the healthcare economy. Economic efficiency determines who, when, where, how much, and allocating healthcare treatments across the population. Think about when you're trying to access the healthcare system that you utilize. Somebody has made a decision on the hours of operation. I had a primary care doc when I lived in San Diego. Their office was open from 7 o'clock in the morning to 6 o'clock at night, which was unique in that San Diego marketplace because most of them were open 8 to 5, but they had an extended on either side of it. And they staggered their physicians, and some worked the early shift, some worked the late shift, but it gave individuals that were working, especially an 8 to 5 shift, the opportunity to not to have to take off work to go to the doctor. They could catch the doctor before they went into work, and they could catch a doctor after they left work and were going home. And it was not only great for the consumer, that individual, but it was great for the company they work for because they didn't lose that lost productivity for them having to take off and go to the doctor. So it's extremely important when you're trying to figure out how to allocate those resources to the consuming population. Consumers and producers maximize utility that leads to market equilibrium. Optimal consumption will be achieved when the marginal benefit equals the marginal cost. And again, producers will produce as long as the marginal benefit is greater than or equal to the marginal cost. And also consumers or optimal consumption will be achieved when marginal benefit does equal marginal cost. And then lastly, and the point that probably need to spend maybe a few minutes on is it talks about it's wasteful to consume all possible medical benefits. The marginal benefit does not offset the medical risk, and the resources can't be used for the next best alternative. And you see this a lot, and I guess the term moral hazard is used more frequently in the P&C, property and casualty area, or maybe it's used in life insurance area, but moral hazard in healthcare is there too, because you have individuals that they will utilize every benefit available to them, whether they need it or not. And their rationale is, hey, I paid for this and I'm going to get every nickel out of it possible. You see it especially with individuals with a pharmaceutical benefit. If they can get a refill, let's say the doctor gives them, a medication and it's got, 5 refills on it. They will go in and continue to get those refills, whether they need them or not, and either stockpile them or sell them. There was a huge racket in markets like Buffalo and other of the larger cities where there was a, large San Diego, especially LA, where there's a large homeless population, individuals getting medications because they could buy them and it was legal to get them through their health benefit plan, and then turning around and selling them on the black market to a homeless population. So that is an overutilization, and it's wasteful because whether it's pharmaceuticals or whether it's office visits or whether it's some other type of healthcare good or service, if it's overutilized or utilized inappropriately or utilized when not required, not only is it's a cost to the health plan, and they will pass that on to the employer group the next time they do a benefit or a premium adjustment. But if it's a government program like Medicaid, Medicare, it's going to cost the government. It's also taking valuable assets and valuable resources away from others in the population. So, you try to make sure that individuals are accessing the healthcare system when they need to and when it's required, but you don't want individuals overutilizing because it is a drain on the healthcare system, and it's definitely a drain on the taxpayer. And the other piece is how are we going to continue to have access to a healthcare system, especially with the immigration policies that we have in place? We're, with the indigent population coming over the southern border, how are we going to take care of those individuals with a healthcare market that is structured based on maybe populations prior to the opening of the southern border? Because remember, once you decide that there is an undersupply of medical providers, it takes a while to build that supply up. Undergraduate, medical school, internship, residency, they may specialize, and then they get out and they start practicing medicine. So it's going to make it, especially with the influx of this indigent population, it's going to make it extremely difficult on healthcare economists as they try to predict or try to forecast the utilization of healthcare goods and services. And it's going to really be an issue if you're a healthcare economist functioning in an area that is negatively impacted by the increase in the immigrant population that's coming into the United States. And just one last thing I want to get out before we wrap this up is, and I had a professor at Ohio State that told me once we were talking about a problem, and we were estimating some healthcare goods and services for the hospital there at Ohio State, and the numbers weren't coming out, and I couldn't figure out. I was having trouble connecting the dots on why things or services tended to be, or they appeared to be, overutilized in a certain department within the university hospital. And sitting there talking with this professor, and professor said, when things don't make sense and they look like they are really out of whack, he said, I've always found, and he said, it's not just in healthcare, he'd worked in multiple fields. And he said, I've always found that, if you follow the money, you will figure it out. He said, when all else fails, he says, it sounds too simple, but when all else fails, follow the money. And sure enough, it was an individual within the hospital system that had a relationship with a pharmaceutical company, and there were issues with the way the pharmaceutical company was interacting with the physicians in a certain area of the hospital, and it was skewing the information or skewing the output that the models were producing. So just always remember, if you don't take anything else away from this class, if you take nothing away from this class, whether you're working on the provider side of that financial coin or the health plan side of that financial coin, or even if you go into government work, if things don't make sense, always follow the money. That's the best advice I can give you. It was the best advice I got out of graduate school, actually. But just always follow the money, because that usually will tell you what's going on and what's happening. And it will help you. It will help you determine and figure out a lot of issues that make no sense whatsoever. With that, I'm going to wrap up chapter 2 as far as, like the role of economics or the role of an economist in healthcare. And the next time we talk, we will jump into, I guess it's chapter 3 of the textbook. Talk to you later.